Hi guys, so in this video we will be talking about nephrotic syndrome, the different diseases associated with nephrotic syndrome, and the key features with regards to symptoms as well as associations, as well as the things you might find on electron microscopy, immunofluorescence, and light microscopy as well for each each disease that can cause nephrotic syndrome. So what is nephrotic syndrome? What is it characterized by? Okay, it's characterized by hyponatremia, hyponatremia, hypoalbuminemia, proteinuria of more than 3.5 grams per day, or 3.5 grams in 24 hours, hyperlipidemia and hypertension, renal vein thrombosis, orbital edema, thromboembolism, infection due to loss of immunoglobulin in the urine, and coagulability due to loss of antithrombin 3 in the urine. So a nice mnemonic would be nephrotic. Sounds like nephrotic, but nephrotic. Okay, so hyponatremia, hypoalbuminemia, proteinuria of more than 3.5 grams per day, hyperlipidemia and hypertension, renal vein thrombosis, orbital edema, thromboembolism, infection due to loss of immunoglobulin in the urine, and coagulability due to loss of antithrombin 3 in urine. So when we were looking at the different diseases that cause nephrotic syndrome, how is a good way to remember these? So I thought of the sort of way to associate in nephrotic syndrome. You can get orbital edema, so sort of edema around the eyes, or facial edema. So my face is mad. Okay, so MF, my face is mad. So minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, amyloidosis, and diabetic glomerular nephropathy. Okay, my face is mad. Minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, amyloidosis, and diabetic glomerular nephropathy. So let's go through each one of these. Minimal change disease, it's the most common cause of nephrotic syndrome in children. Okay, so most common cause of nephrotic syndrome in children. Okay, it's often idiopathic. Okay, that's another key word, idiopathic. Okay, however, it can be triggered secondarily to infection, immunization, okay, and immune stimulus. Okay, and rarely, but very important, rarely due to lymphoma. Okay, rarely due to lymphoma. Okay, so this disease has good response to steroids. Okay, good response to steroids. That's very important. Good response to steroids. So if you see an option of either giving the patient steroids or giving them or doing a renal biopsy to confirm first for minimal change disease. Okay, if it's proven that it's minimal change disease, steroids. If it still doesn't resolve due to steroids, then you may need to do a renal biopsy to see what's going on. Okay, so what are the features? Okay, what are the features? So in this video series, you will see the words, the letters LM, IF, and EM. LM is light microscopy, IF is immunofluorescence, and EM is electron microscopy. Okay, so on light microscopy, it will be normal glomeruli. Okay, immunofluorescence will be negative. Okay, immunofluorescence will be negative, and electron microscopy will show effacement of podocyte foot processes. Okay, so light microscopy will show normal glomeruli, immunofluorescence will be negative, and electron microscopy will show effacement of podocyte foot processes. So in this video, to make it systematic, we will go in this order: light, then immunofluorescence, then electron, LIE, lie. Okay, we'll go in this order. Okay, so that is minimal change disease. Now, focal segmental glomerulosclerosis. Okay, this is most common in African American population and the Hispanic population. Okay? It can be idiopathic or it can be secondary to conditions such as HIV, sickle cell disease, heroin abuse, obesity, interferon treatment, or congenital malformations. Okay, so focal segmental glomerulosclerosis is common in the African American and the Hispanic population. It can be idiopathic or it can be secondary to HIV, sickle cell disease, heroin, obesity, interferon treatment, or congenital malformations. Okay, so what will we see? Okay, we will see on light microscopy, we will see segmental sclerosis, which makes sense. Glomerulosclerosis, on light microscopy, we will see segmented sclerosis. Okay? On immunofluorescence, it's often negative, but may have non-specific IgM C3 or C1, which are complements. So non-specific IgM C3 or C1 deposits. Okay? So light microscopy, segmental sclerosis. Okay? And immunofluorescence, most likely negative, but may show non-specific deposits of IgM, C3, and C1 deposits. And your electron microscopy, okay, electron microscopy will show effacement of podocyte foot processes, which is similar to your minimal change disease. Okay. Now let's go to membranous nephropathy. Okay. Membranous nephropathy, also known as membranous glomerulonephritis. Okay, but in the interest of nephrotic syndrome, we will keep it as membranous nephropathy for now. But it can also be known as membranous glomerulonephritis. Okay. It can be primarily due to antibodies to phospholipase A. Antibodies to phospholipase A2 receptor. Okay, so primarily it can be due to antibodies due to phospholipase A2 receptor. Okay, secondarily to drugs such as NSAIDs. So NSAIDs are your painkillers such as ibuprofen, such as your naproxen. Those are your NSAIDs. And also can be due to penicillamine use, which is a copper chelating agent used in Wilson's disease. Okay, or it can be due to the use of gold, which was previously used for things like rheumatoid arthritis, but not so common anymore. It can also be due to infection, such as hepatitis B virus, hepatitis C virus, and syphilis. Okay, and it can also be due to systemic lupus erythematosus or solid tumors. Okay, so these are what can cause membranous nephropathy. It can either be primarily due to antibodies to the phospholipase A2 receptor, okay, phospholipase A2 receptor, or it can be secondary to drugs such as NSAIDs, penicillamine, or gold, or it can be due to infections such as hepatitis B, hepatitis C, or syphilis, or due to systemic lupus erythematosus, SLE, or solid tumors. Okay, so what are the features that we will see? The features that we will see on light microscopy will be diffuse, capillary, and glomerular basement membrane thickening. Okay, think of it this way: membranous membranes, lot of membranes makes it thick. Okay, lot of membranes, membranous nephropathy, lot of membranes makes it thick. That's one way of trying to remember that on a light microscopy, you'll see diffuse capillary and glomerular basement membrane thickening. Okay? On immunofluorescence, what will we see? We will see granular appearance. Okay? Granular appearance due to immune complex deposition. Okay? So remember, we have antibodies over here. Antibodies can form immune complexes. Think of it that way. Granular immune complex deposition. Okay, granular immune complex deposition. And your electron microscopy can show a spike and dome appearance of sub-epithelial deposits. Okay, so membranous nephropathy is primary. It can be primary or secondary. Primary due to antibodies to the phospholipase A2 receptor. Secondary to drugs such as NSAIDs, penicillamine, or gold. It can be due to infections such as hepatitis B, hepatitis C, or syphilis, and it can also be due to SLE or solid tumors. So what will we see on light microscopy? Light microscopy, we can see diffuse capillary and glomerular basement membrane thickening. On immunofluorescence, granular appearance due to immune complex deposition. And on electron microscopy, you can see the spike and dome appearance of subepithelial deposits. Spike and dome. Okay, so how will we remember spike and dome? Okay, the moment we say SLE, S for spike. Okay, S for spike. Think of it that way. Okay, or actually much better, we can go to solid. The word solid tumors. Okay, solid tumors, S for spike and D for dome. Spike and dome appearance. Okay, so try to link all this together. So light microscopy, due to the membranous membranes, a lot of membranes, so diffuse capillary and glomerular basement thickening. So, and then antibodies is another key word. Immunofluorescence, granular immune complex deposition. Okay, and then finally on your electron microscopy, you have the spike and dome appearance due to of the subepithelial deposits. Okay, so that is membranous nephropathy. Now let's go to amyloidosis. Okay, amyloidosis. So amyloidosis is basically protein deposition in different tissues, which can end up causing organ dysfunction. Okay, so with amyloidosis, the most commonly involved organ is the kidney. Okay, when there is systemic amyloidosis. Okay, amyloidosis is associated with chronic conditions. Okay, chronic conditions that predispose to amyloid deposition. This can include rheumatoid arthritis. This can include Alzheimer's. Alzheimer's has beta amyloid plaques. Okay, so Alzheimer's as well. Okay, in this one, amyloidosis, the most important thing is the fact that you only have light microscopy findings only. Okay, amyloidosis. Okay, so only L. Light microscopy, amyloidosis. Okay, so only light microscopy findings, where you will see Congo red stain would show apple green bifringence. Okay, under polarized light. You would have amyloid protein deposition in the mesangium. Okay, so amyloidosis, commonly due to conditions that predispose to amyloid deposition, such as rheumatoid arthritis, Alzheimer's disease, for example, and you'll only have light microscopy, because amyloidosis, only L, light microscopy, will show when you put a Congo red stain, will show apple green bifringence under polarized light. Okay, due to amyloid deposition in the mesangium. Okay, and last but not least, we have the diabetic glomerular nephropathy. Okay, so diabetic glomerular nephropathy is the most common cause of end-stage renal disease, especially in the United States. Okay, so what happens over here? Okay, and this is a very important process to follow. Okay, you have hyperglycemia. Okay, hyperglycemia. So obviously, diabetic patients, if it's not well controlled, you can have severe hyperglycemia. Okay, what does hyperglycemia do? It causes non-enzymatic glycation of tissue proteins. So let's think about it this way. What is an easy way to remember this? Hyperglycemia, a lot of sugar going around. Sugars, glucose, glycogen. So sugars are basically, they're the boss. All right, they don't need no enzymes. So no enzymes are needed. They go and basically sugarcoat these tissue proteins. Okay, they go to the tissue, go to the proteins, and they sugarcoat them. They don't need any enzyme to do it. They're the boss. Okay, so hyperglycemia, non-enzymatic glycation of tissue proteins. Okay, once that happens, you get mesangial expansion, because obviously you're sugarcoating them, right? They're gonna be all happy and loose, and like they're gonna start, growing big, right? So mesangial expansion. Okay. Then what does mesangial expansion do? It causes glomerular basement membrane thickening, and once this once the glomerular basement membrane thickens, what does this do? This causes increased permeability. Okay? It causes increased permeability. Due to the increased permeability, you end up getting hyperfiltration. Okay? With the hyperfiltration, because there's increased permeability, more fluid can go in and out. Hyperfiltration causes glomerular hypertension. Okay, and this can also cause increased glomerular filtration rate as well. Okay, when this happens, you get glomerular hypertrophy. Okay, and glomerular, I swear that's a hard word to say, glomerular scarring. Okay, so when you get the scarring, you have glomerulosclerosis. Okay, and this causes further progression of nephropathy. Okay, so what do we have here? You have hyperglycemia, the sugars are the boss. All right, so they go around, they go to the tissue proteins and they sugarcoat them. And they don't need no enzymes to do it. So this is non-enzymatic glycation of tissue proteins. Once that sugar coating happens, they get all big and they get all happy. This leads to mesangial expansion. When mesangial expansion happens, the glomerular basement membrane thickens. What happens when it thickens? It causes increased permeability. When there's increased permeability, there's hyperfiltration. There's hyperfiltration, a lot of fluid going in and out, a lot of business going in and out, right? Thanks to the whole sugar coating thing. A lot of business going in and out. You get a lot of stress as well when there's a lot of business. So you get glomerular hypertension. When there's glomerular hypertension, there's a lot of fluid moving in and out. You also get increased glomerular filtration rate as well. Okay? So when there's a lot of business going around in the glomerulus, going in and out, in and out, in and out, a lot of business, you get glomerular hypertrophy because there's a lot of work to do, so you need to get much more stronger. Okay? There's hypertrophy, you also get scarring as well because you got a lot of work to do, but you're so stressed out. Okay, you're going to cause damage to yourself too. So glomerular scarring, which leads to glomerulosclerosis, right? Due to this glomerulosclerosis, you have further progression of nephropathy. Okay, so what would we see on any of the microscopies? We will only see findings on light microscopy. Okay, again, light microscopy, glomerulonephropathy, light microscopy. Okay, let's use a different color for this. Light microscopy, what will we see? We will see the mesangial expansion. Okay, remember the sugar coating, mesangial expansion. Okay, we will see the GBM thickening, glomerular basement membrane thickening. Okay, what else will we see? We will see Kimmelstein. This is one of the key words. Kimmelstein-Wilson bodies. Okay, Kimmelstein-Wilson bodies, which are basically due to the glomerular sclerosis. You have eosinophilic nodular appearance of the glomerular sclerosis. Okay, you have I will write it slowly in a small way over here. eosinophilic nodular glomerulosclerosis. Okay, this is what you will see with the chemosteen bodies. Okay, so these are basically the features of nephrotic syndrome. So let's go through them a little bit quickly again. Nephrotic syndrome, okay. Remember the mnemonic nephrotic, okay. You have hyponatremia, hypoalbuminemia, proteinuria of more than 3.5 grams per day, okay. So NAP, and H, hyperlipidemia and hypertension, okay. Then what else will you have? You can also get renal vein thrombosis. Okay, you can get orbital edema. You can also cause thromboembolism. You can have infection due to loss of immunoglobulin in the urine, and coagulability due to loss of antithrombin 3 in the urine. Okay, so there are 5 diseases that can cause nephrotic syndrome. MFMAD, my face is mad. Periorbital edema, my face is mad. Okay, the first one, minimal change disease. Minimal change disease commonly seen in children. It's usually idiopathic but can be secondary to either infection, immunization, or immune stimulus. Okay, a very good response to steroids. Okay, if refractory to steroids, then consider renal biopsy. Okay, on light microscopy, it's normal glomeruli. Immunofluorescence is negative, and on electron microscopy, you will see effacement of the podocyte foot processes. Okay, focal segmental glomerulosclerosis. It's common in African American and Hispanic populations. Okay, it's usually idiopathic but can be secondary to HIV, sickle cell disease, obesity, interferon treatment, and congenital malformations. Okay, so what will we see? Light microscopy, glomerulosclerosis. So you will see segmental sclerosis. Immunofluorescence is usually negative, but you might see non-specific IgM deposits, C3 or C1 deposits. Okay, and with electron microscopy, you will see the same thing with minimal change disease, effacement of the podocyte foot processes. Okay, so now we move on to the next one, membranous nephropathy. Membranous nephropathy can be primary or secondary, primarily due to antibodies to the phospholipase A2 receptor, or it can be secondary to drugs such as NSAIDs, penicillin, or gold, infections such as hepatitis B, hepatitis C, or syphilis, or it can be due to SLE and solid tumors. Okay, so what are the features? So light microscopy. Light microscopy, you can see there's diffuse capillary and glomerular basement membrane thickening, membranous thickening. Okay, next one, on immunofluorescence, you can see a granular appearance due to immune complex deposition. Remember, antibodies, immune complex. All right, and on electron microscopy, you can see the spike and dome appearance. Okay, for membranous nephropathy, spike and dome appearance. Okay, amyloidosis. For amyloidosis, you will see it's commonly associated with rheumatoid arthritis and Alzheimer's, for example, and you will only amyloid L. Light microscopy, you will see that the Congo, if you apply the Congo red stain, you will see that there's an apple green bifringence under polarized light. Okay, this is amyloid protein deposition in the mesangium. Okay, and finally, diabetic glomerular nephropathy. It's due to the hyperglycemic state, increased sugars. So what will happen? Sugars don't need no enzymes; they're the boss, so they go non-enzymatic glycation of tissues. Okay, what does that cause? That causes mesangial expansion. Mesangial expansion causes the glomerular basement membrane thickening. Once that thickens, what will happen? You have increased permeability, which results in hyperfiltration. Hyperfiltration causes glomerular hypertension and increased glomerular filtration rate. Once that happens, you have glomerular hypertrophy, okay, and scarring, leading to glomerular sclerosis, which is further progression of the nephropathy. And glomerulopathy, L, light microscopy, you will see mesangial expansion, glomerular basement thickening, and the Kimmel-Steele-Wilson bodies.